Anchor. Today we're going to be looking at ultrasound evaluation of the liver, part 2. But before we begin, please like, share, subscribe, and put on notification to receive all our free lectures. For more information about our paid classes, please send an email to sonoeyesdiagnostics@gmail.com or WhatsApp me at +234 9019144175 or visit our online store at sonoeyes.business.site. Attempt the quiz in the description and leave me a comment. You're welcome back. Today we'll look at diffuse parenchymal disease and other forms of pathology, beginning with cirrhosis of the liver. Cirrhosis is a diffuse chronic liver disease that is characterized by loss of normal function and structure. It is the consequence of prolonged and severe insult to the liver cells that will result into hepatocellular death. The normal liver architecture is replaced by fibrosis and nodular regeneration. This disease is irreversible and can lead to liver failure, portal hypertension, hepatocellular carcinoma, and eventual death. The most common cause is chronic alcohol abuse, followed by viral hepatitis, nutritional deficiencies, and drugs. Biliary cirrhosis is caused by prolonged bile duct obstruction, resulting in liver cell death from back pressure. Cardiac cirrhosis is caused by prolonged right-sided heart failure, which prevents adequate liver drainage into the IVC by the hepatic vein. You call that a passive congestion of the liver. Causes of cirrhosis or fibrosis. Alcohol-related disease is the major. It accounts for about 60 to 70% of all cases in the Western world. Viral hepatitis, especially B and C, are a common cause in Asia and Africa. Biliary disorders, primary biliary cirrhosis, chronic biliary cirrhosis, sclerosing cholangitis, all grouped under biliary disorders. Metabolic disorders, you have hematochromatosis, Wilson's disease, type 4 glycogen storage disease, alpha-1 antitrypsin deficiency, galactosemia, tyrosinemia. In cardiovascular diseases, you have passive cardiac congestion, Budd-Chiari syndrome, veno-occlusive disease. Drug and toxin related, you have methotrexate, cyclophosphamide, vitamin A, D, and E, and so on. Immunologic conditions, you have leukoid hepatitis, and other issues will be grouped under miscellaneous, such as sarcoidosis and cryptogenic issues. What are the clinical features of diffuse parenchymal disorder? The clinical features will depend on the stages of the disease. No symptoms in early stage of the disease, but progressing to non-specific complaint of fatigue, weight loss, abdominal pain, and abdominal distension. As the disease progresses, hypoalbuminemia, ascites, skin changes, palmar erythema, spider nerve. You see that on the skin. Abdominal liver function test will be one of the things that you see in the lab. jaundice and portal hypertension become very evident. Cirrhosis may lead to potentially life-threatening conditions. Hepatocellular failure will occur due to hepatocyte damage, GI tract hemorrhage, like you begin to have hematemesis and melena resulting from esophageal varices due to portal hypertension. The incidence of the hepatocellular carcinoma is also very high with cirrhosis, which is stronger with hepatitis than alcoholism. Sonography signs of cirrhosis. In early cirrhosis, the sonography signs are usually subtle and limited to hepatic parenchyma, and sometimes difficult to distinguish from fatty infiltration. And these are mild to moderate hepatomegaly, coarse echo texture of the liver parenchyma, diffusely coarse inhomogeneous echo pattern, increased echogenicity or brightness, of course. Surface nodularity usually will not be visible without scanning with high frequency transducer, about 7.5 is reasonable. The hepatic vein Doppler will be altered and will show loss of normal flow. Reversal. This may be the earliest ultrasound abnormality you will see in cirrhosis, about 75% of the case. Note that fatty infiltration is sonographically similar to early cirrhosis, so you may want to do follow-up and other clinical and laboratory investigations. In late or advanced cirrhosis, a combination of intrahepatic and extrahepatic ultrasound findings suggests diagnosis of advanced cirrhosis. Intrahepatic findings will include reduced liver size, small and shrunken liver, coarse echo pattern will become more pronounced than in the early stages, diffusely coarse inhomogeneous echo pattern, increased echogenicity, surface nodularity. Nodularity of the liver surface will be easily visible at this late or advanced stage. Volume of the volume distribution, you will have caudate lobe to right lobe ratio of greater than 0.65, which is highly specific for 85% of the cases and moderately sensitive in the disease of cirrhosis. Following other parameters is also in use. For example, enlarged caudate lobe and left lobe or small right lobe. So you have enlarged caudate lobe and left lobe, which are larger than the small right lobe when you do the comparison. Caudate lobe to right lobe ratio will be greater than 0.65 in ratio. Transverse sonogram measurement. Right lobe, left lobe ratio will be less than 1.3. Left portal vein diameter will be greater than or equal to right portal vein diameter. Extrahepatic findings of cirrhosis are mainly resulting from portal hypertension and are splenomegaly, spleen size will be greater than 13 centimeters in length. Portal vein enlargement, you can have anterior-posterior diameter of greater than 13 mm or 15 mm. Splenic vein and SMV enlargement, superior mesenteric vein enlargement, you have anterior-posterior diameter of greater than 10 mm. Loss of respiratory variation in diameter of the PV and the SV. Reduce or even reverse main portal velocity. Portal portal vein may be thrombosed. Hepatofugal portal venous flow you observe instead of hepatopedal flow. Cavernous transformation of the portal vein around the portal hepatis and the main portal vein. Protosystemic collateral shunts. You see esophageal varices via the short gastric or left gastric veins, splenic hilar varices via splenorenal and splenogastric veins, recanalization or recanalized para-umbilical vein via the ligamentum teres, a patent or recanalized umbilical vein with hepatofugal flow is highly specific for diagnosing portal hypertension. As part of the extrahepatic finding, you will have ascites. This results from a combination of portal hypertension and hypoalbuminemia. Ascites makes surface nodularity of the liver more visible. Now, this image shows cirrhosis. You can see the coarse echo pattern. Transverse view shows a coarse echo pattern, especially in the left lobe. You can see those black arrows. Then this other image, you have a coarse echo pattern. Also notes increased attenuation of sound secondary to superimposed fatty infiltration. In this image, you are looking at surface nodularity, transverse and sagittal view of the liver surrounded by ascites, show nodularity of anterior surface of the liver. Then this image marked surface nodularity. Transverse view here shows marked nodularity. You can see the white arrows shows the anterior surface of the liver surrounded by ascites and small shrunken liver. In this image, you have relatively enlargement of the caudate lobe. When you look at the transverse view, shows an enlarged caudate lobe. C represents the caudate lobe. Then we have enlarged caudate lobe in this image. Transverse view also shows enlarged caudate lobe and a small right lobe. Now this is a sketch to show how to measure ratio of caudate lobe to right lobe volume distribution of liver. Now, Doppler of hepatic vein in cirrhosis. In duplex Doppler imaging of the hepatic vein of patients with cirrhosis, the normal triphasic pattern of the hepatic vein may be lost and will show monophasic waveform, probably because of decreased compliance of the vein secondary to fibrosis and steatosis in parenchyma surrounding the hepatic vein. This may be the earliest sign of cirrhosis in about 75% of the statistical cases. Regenerating nodules. Now, cirrhotic liver contain numerous regenerating nodules, or you want to say adenomatous hyperplasic nodules, most of which will range from 5 mm to 1.5 centimeter. Now, if large, greater than 5 mm, can be seen by ultrasound and will appear hypoechoic, frequently with a thin echogenic ring. Micro nodules, the small nodules that are less than 5 mm, rarely is visualized by ultrasound exam and are called micro nodules. But macro nodules are large regenerating nodules greater than 5 mm, and we call it macro nodules, and may appear as an echogenic or inhomogeneous solid mass that cannot be differentiated from hepatocellular carcinoma, or other neoplasm. However, Tectinium-99 sulfur colloid scintigraphy may detect the regenerating nodule because they take up the radionuclide, whereas the neoplastic tissue has decreased or absent uptake. So that's one of the ways to know whether these micronodules or macronodules you are looking at actually regenerating nodules or they are neoplasm. So where the neoplasm will not take up the Tectinium-99M, but the regenerating nodules will. So, however, biopsy is often necessary for this diagnosis. So, you want to take due diligence. So, in this case, in this image, you see a regenerating nodule. Sagittal view shows biopsy-proven small hypoechoic solid regenerating nodule in a cirrhotic liver with a coarse pattern. Then in this image, you have a hepatoma or hepatocellular carcinoma. Here you have multifocal hypoechoic nodule. You can notice that in that image in a background of cirrhosis and ascites. Let's take a quick look at biliary cirrhosis. Primary biliary cirrhosis is a chronic progressive cholestatic liver disease of unknown cause, and is characterized by inflammation and distribution of intrahepatic bile ducts. It occurs in all races worldwide. Most patients are white. 95% of people with primary biliary cirrhosis are women. Between the ages of 30 and 65. The liver is enlarged and smooth in the early stages of the disease, but also the disease progresses. It may become, as the disease progresses, it may become finely nodular. Sonographically, it reflects abnormality. The findings will reflect abnormalities that are secondary to cirrhosis. Enlarged lymph nodes are frequently seen in the porta hepatis. Endoscopic retrograde cholangiopancreatography is the primary radiographic technique for establishing diagnosis of primary biliary cirrhosis, whereas secondary biliary cirrhosis results from long-standing biliary obstruction, cholangitis, and biliary atresia. Cardiac cirrhosis, what you want to call passive congestion of the liver. A patient with CCF or RCF due to elevated systemic venous pressure develop marked dilatation of intrahepatic vein and the IVC, which produce significant liver function test abnormalities. In other words, LFT abnormalities. Yeah. Sonographically, the diameter and the length of the hepatic vein and the IVC visualized are greater than normal. In Doppler, hepatic vein do not show phasic collapse with respiration, or we show monophasic instead of normal triphasic pattern. This may be the earliest sign of cirrhosis in about 75% of the cases. The sonologist should be alert to this situation, since this may be the first indication that the problem is cardiac rather than hepatic in origin. In progressive CCF, liver will be damaged, resulting in cardiac cirrhosis. IVC will have an increased diameter and will no longer be influenced by respiration. Let's look at other diffuse parenchymal liver disease. Take glycogen storage disease, for example. It is an autosomal recessive genetic disorder of glycogen metabolism that is manifested in the neonatal period by hypoglycemia, hepatomegaly, and nephromegaly. Type 1 glycogen storage disease, otherwise known as von Geke's disease, is the most common. There is excessive glycogen deposit in the hepatocytes and proximal renal tubule. It causes hepatomegaly and may cause diffuse increased echogenicity that is secondary to concomitant fatty infiltration of the liver. The incidence of benign hepatic adenoma is increased in patients with type 1 glycogen storage disease. There is also the congenital generalized lipodystrophy. It is a rare hereditary disease that causes hepatomegaly and increased echogenicity and attenuation of sound, secondary to fatty infiltration of the liver. Cystic fibrosis, in this case, we have diffuse increased echogenicity of the liver. You also have the inhomogeneous echo pattern and increased periportal hyperechogenicity that will be seen, along with small gallbladder containing sludge. Hematochromatosis. The sonographic abnormalities are related to fibrosis and cirrhosis of the liver. Parenchymal iron deposits in the liver usually do not cause any alteration of the liver echogenicity. Patients have hepatomegaly and frequently splenomegaly. You have amyloidosis. In ultrasound, you show non-specific abnormality. The liver is enlarged and may have an inhomogeneous echo pattern. Whereas in Wilson's disease and Gaucher's disease, it's also non-specific abnormalities in sonography related to infiltration and cirrhosis. Patients with AIDS may have hepatomegaly and increased echogenicity in the liver. Now, vascular abnormalities and disorder that could occur in this pathology, you have portal vein anomaly, portal hypertension, portal vein thrombosis, portal vein aneurysm, hepatic vein abnormally, under which you can have Budd-Chiari syndrome, hepatic artery anomaly, you can have hepatic artery aneurysm and pseudoaneurysm, hereditary hemorrhagic telangiectasis, intrahepatic portal photosystemic venous shunt. For portal hypertension, this is defined as a portal vein pressure in excess of normal by 5 to 10 millimeter mercury. Portal hypertension results from increased resistance to portal blood flow. It can also be caused by increased flow into the portal system, called hyperkinetic portal hypertension. The causes of portal hypertension can be divided into 3 major groups according to the level of obstruction or increase in resistance to the portal venous flow. We can have the prehepatic, intrahepatic, and post-hepatic. For the prehepatic portal hypertension, it can be caused by portal vein thrombosis, splenic vein thrombosis, splanchnic arteriovenous fistula, and splenomegaly. For intrahepatic portal hypertension, it can be caused by alcohol cirrhosis, chronic active hepatitis, schistosomiasis, sarcoidosis, myeloproliferative disease, malignant disease of the liver, primary biliary cirrhosis, Wilson's disease, Budd-Chiari syndrome, or hepatic vein occlusion, veno-occlusive disease, and idiopathic portal hypertension. Whereas the post-hepatic portal hypertension can be caused by IVC obstruction and cardiac disease like CCF, constructive pericarditis. Causes of portal hypertension can also be divided into pre-sinusoidal, sinusoidal, and post-sinusoidal. The pre-sinusoidal portal hypertension is considered to be pre-sinusoidal if the wedge hepatic venous pressure is normal or less than the portal pressure. Sinusoidal if the wedge hepatic venous pressure is increased and equal to portal pressure. And it's considered post-sinusoidal if the site of obstruction to the flow is distal to the sinus, that is hepatic vein or the heart. Alcoholic cirrhosis is the most common cause of portal hypertension in Western nations, but hepatic vein occlusion, portal vein occlusion, and schistosomiasis are other frequent causes of portal vein obstruction. Chronic active hepatitis induced cirrhosis is the most common cause of portal vein obstruction in Asian nations. The sonographic findings of portal hypertension, you see splenomegaly, ascites, cavernous transformation of periportal vein, and portosystemic venous collateral. Several other parameters of grayscale, duplex, and color Doppler sonography of the portal venous system and portosystemic collateral can be helpful in diagnosis of portal hypertension. These parameters are discussed as we go on in other paragraphs. Portal vein diameter. Main portal vein diameter is greater than 13 mm would indicate portal hypertension with a high degree of specificity. Portal vein diameter is measured on sagittal view during deep inspiration with the patient in supine position. Although the diameter of the main portal vein may initially increase because of increased portal venous pressure, later, as severe portal hypertension develops, the portal vein diameter may decrease, probably because more blood is diverted to the portosystemic collateral. Splenic and superior mesenteric diameter. The diameter of the splenic vein usually is greater than 10 mm in transverse view at the level of the superior mesenteric artery, and the diameter of the superior mesenteric artery is greater than 10 mm in sagittal view close to the confluence of the splenic vein. The diameter are measured during deep inspiration with the patient in supine position. Respiratory variation in venous diameter in healthy person. The diameter of the splenic vein and the superior mesenteric vein increases about 50 to 100% in inspiration compared with the diameter in expiration. Patients with portal hypertension lack normal diameter variation. In this case, it will be less than 50% during deep inspiration. Flow direction in portal vein. In healthy person, the flow in the main portal vein is hepatopedal, that's towards the liver. Detection of hepatofugal flow in the main portal vein is specific sign of portal hypertension. Reversal of the direction of flow may also be seen in the splenic vein. To and fro flow in the main portal vein is another sign of portal hypertension and is best seen during the active breathing. Inspiration draw blood towards the liver, that is hepatopedal flow, whereas expiration will reverse blood, that is hepatofugal flow. To and fro flow in the main portal vein may also be seen in patients with right side heart failure. The portal vein velocity and flow. The normal flow velocity in the main portal vein is about 15 to 18 centimeters per second. In patients with portal hypertension, the velocity and flow in the portal vein are usually decreased. In gastric vein diameter or coronary vein diameter, in patients with portal hypertension, the coronary vein, that's left gastric vein, may be dilated. Coronary vein diameter of 5 mm or larger has a sensitivity of about 80% in diagnosis of portal hypertension. A coronary vein diameter larger than 7 mm is associated with severe portal hypertension. Dilated coronary vein can be seen posterior to the left lobe of the liver, extending cranially from the splenic vein near its confluence with the superior mesenteric vein on the sagittal view. In portal hypertension, color Doppler or color sonography may demonstrate reversal of flow direction, that is away from the splenic vein within the coronary vein. Reversal of flow direction within the coronary vein may be more sensitive, sonographic indicator of portal hypertension than the coronary vein dilatation. Then the esophageal varices, that is the dilated gastroesophageal collateral veins, may be seen near the esophageal junction, that is esophageal to gastric junction, posterior to the left lobe of the liver, close to the diaphragm. These are communications between the left gastric vein and the systemic esophageal vein. 1/3 of the deaths from cirrhosis are secondary to hemorrhage, usually from esophageal varices. The splenic hilar varices, in this case, that is the dilated splenorenal and gastrorenal collateral, can be seen as large tortuous vein in the region of the splenic and left renal hilar. Now remember the recanalization with respect to paraumbilical vein. This causes in the fissure for ligamentum teres and connects the left portal vein with the systemic vein around the umbilicus. On physical examination, it may cause a paraumbilical venous hump, what you call Creuveria-Boumartin syndrome. A dilated paraumbilical vein is seen on transverse view as an anechoic round structure within the ligamentum teres. Its origin from the left portal vein is caused posterior to the anterior abdominal wall, and it terminates near the umbilicus. They are best seen on longitudinal view. Clinically, it can be seen in the anterior abdominal wall as caput medusa. In portal hypertension, color Doppler sonography will show hepatofugal flow within the dilated paraumbilical vein. A segment of remnant of the umbilical vein may be normally patent in about 16% of healthy persons without portal hypertension. Therefore, a paraumbilical vein should be considered diagnostic for portal hypertension only if the diameter of the portal vein is larger than 3 mm, or if the hepatofugal venous flow has a velocity that is greater than 5 centimeters per second, so that you will be able to differentiate from what is a normal variation to what is actually a pathology. Cavernous transformation of the portal vein. With long-standing occlusion of the main portal vein, adjacent collateral veins enlarge and permits continuous hepatopedal flow of blood. These collateral channels represent cavernous transformation of the portal vein. Sonographic demonstration will show multiple serpiginous, tortuous, periportal collateral veins in expected locations of the main portal vein. The thrombosed main portal vein is usually not visible on grayscale sonogram because of numerous periportal collateral vein in the expected location of the main portal vein. Color Doppler sonography demonstrates the absence of flow within the main portal vein and color flow in the periportal vein, collateral vein. The flow in periportal collateral vein is in hepatopedal direction and has a portal venous waveform. Other less frequent collateral veins will include the pancreaticoduodenal, retroperitoneal, paravertebral, omental, and hemorrhoidal veins. Now, this sketch is a popular sketch for portal hypertension, the pathways, where you have the major portosystemic venous collaterals and the cavernous transformation of the portal vein. So I want to thank you for joining this lecture today. Please like, share, subscribe, and put on your notification to receive all our lectures, all our free lectures. For more information about our paid classes, please send me an email to sonoeyesdiagnostics@gmail.com or WhatsApp me at +234 9019144175 or visit our online store at sonoeyes.business.site. Attempt the quiz in the description and leave me a comment. Until the next time I come your way again, keep learning ultrasound.